Welcome to my talk. I am David Ramirez. I am a fourth-year PhD candidate in the Visible Heart Laboratories at the University of Minnesota, and this is my talk about the utilization of optical coherence tomography to assess coronary vessel constriction after ablation. Cardiac ablations have been used to treat cardiac arrhythmias for several decades. The typical way to deliver this ablative therapy is utilizing radiofrequency. Radiofrequency has been known to cause stenosis of vessels in preclinical studies and in clinical studies. A new ablation modality called irreversible electroporation is becoming more and more widely used in cardiac ablations. In the image to the right, you can see a 2 weeks study of irreversible electroporation compared to radiofrequency ablation. And in it, it shows that the radiofrequency ablation will cause pulmonary vein stenosis, whereas the irreversible electroporation does not. However, in this study, we aim to look at the acute response of irreversible electroporation versus radiofrequency ablation modalities in order to see how the coronary vessels respond. In order to see the effects of the different ablation modalities on the coronaries, we decided to use Optical Coherence Tomography, or otherwise known as OCT. OCT is a developing tool that is being used by EP cardiologists to look at the vessels when they're placing stents. However, what it gives you is a view of not just the lumen of your vessels, but it gives you area and it gives you diameter of your vessels. So using this tool, we have been able to place it inside an ex-vivo reanimated swine heart at the Visible Heart Laboratories, and since we have a clear buffer, we can actually see the laser tip of the catheter. So we can place it in the LAD, and if you look at the video, you can actually see the laser being placed at the most distal part of the LAD. Concurrently with that, we can actually see and take a baseline of 5 centimeters of our LAD prior to giving the ablation energy. Once we have taken this baseline measurement, we can actually apply our energies, and we have several spots where we can do it, and we can randomize whether we do radiofrequency or we can do one of our 2 power settings for irreversible electroporation. So we have decided to do 700 volts or 500 volts, and then we've done 30 watts for radiofrequency. In the image on the top right, you can see the OCT catheter in relation to the IRE ablation needles. After the ablation has been performed, we can actually take a post-ablation OCT, and then we can look at the quantified measurements for our area changes and our diameter changes. Our results from our experiment show that there's definitely a reduction in vessel size in both area and diameter from both ablation modalities. What is interesting, however, is that while the IRE does not show any chronic damage to the vessels in certain studies, it is definitely a higher acute effect than radiofrequency. This effect also is compounded as you go into higher and higher energies, which is something that you might want to do depending on the thickness of the muscle to be able to achieve transmurality. So in the future, we plan to repeat the studies and look at a time course and see how the vessel recovers or does not recover, and actually also increase the energies to be able to see if there's any damage to the lumen of the vessels. Thank you so much for the talk, and if you have any questions, feel free to reach out. I'll be here during the talks, and anywhere you can find my email and give me some questions. Thank you so much.